All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound case series. This is our last week for the 2022 series, and we'll begin again in early 2023, and I'll mention that again at the end here. But this morning, we have Dr. Anthony Joseph presenting. He'll be presenting on proximal tibiofibular subluxation. Dr. Joseph completed a sports medicine fellowship at the University of Minnesota. He has served as a team physician for Idaho State University. He currently works with collegiate athletes and high school athletes, among other individuals in his practice. His interest initially in sports ultrasound was sparked by a rheumatology colleague who recommended that he look into this, and he took it up and has really become quite a highly skilled sonographer. I've had the pleasure of seeing Dr. Joseph speak a couple of times here and pick his brain with a couple of different things, and he's really thinking kind of next level sort of stuff in sports ultrasound, and so I'm really excited for him to present today. Outside of medicine, he's a really avid athlete. He enjoys skiing and mountain biking, and he is a gardener and enjoys cooking from his garden. So I will stop sharing and I'll let you take it away, Dr. Joseph.
All right. Thanks, Ryan. Let me get to this. Today I'm going to talk about instability of the proximal tibiofibular joint, and from the point of a case that I saw in this last year. And so what I'd like to do is describe a complete knee ultrasound evaluation. Compared to shoulders, I do very few complete knee ultrasound evaluations, but in this case, I felt like I needed to because there were a lot of questions that weren't answered. And so, as we can do in all our complete examinations, we can expand those for a dynamic evaluation. And so, in this case, we are going to look at a dynamic evaluation of the proximal tibiofibular joint, and I'll kind of explain how that came about. So, in this patient, this is a 20-year-old female who presented almost a year and a half after she had a left lateral knee injury, and she had persistent left lateral knee pain. And basically, she worked at a big box store. She was carrying a lot of heavy freight on a large cart, and this cart that she was either pushing or pulling, the freight on the cart came down and landed on the outside of her left knee and leg. She landed on the ground. She hit a pothole she didn't see. And when that happened, she developed a significant amount of lateral knee pain, and we'll see why here in a minute. The problem that I ran into is the patient still struggled with everyday activities such as standing, walking downstairs. But more importantly, she was a competitive runner in high school and continued to run and for overall fitness, but couldn't run because of the pain on the outside of her knee. And so the patient also stated she couldn't bend and straighten the knee fully. But she noticed something there, an instability, a sense of shifting. And this is a video sent to us by the patient. This is the patella over here. This is the fibular head here. And you'll see the subtle movement when she goes into flexion. And this is what she demonstrated when she came into the office to see me. And of course, you can see the marks where she's been taping it from her physical therapist. So, the interesting thing is she went through physical therapy, didn't get better, had an MRI that we'll see, and she had arthroscopic treatment. And the question mark is why she had arthroscopic treatment, because there really wasn't anything on her MRI to suggest that. So a radiologist, an MSK radiologist that I know very well, injected steroids in the proximal tib-fib joint, and she got temporary relief, approximately a week or two, but then the pain returned. He did this twice, and she continued physical therapy and conservative treatment without improvement. So just to go through her radiographs, these were done on my visit when I saw her, and there were no clues to why she was having lateral knee pain. She had good patellofemoral alignment, perhaps a little bit of patella alta, but I could not see any abnormalities of the proximal tib-fib joint. And then on her MRIs, her initial MRI done on in September of 2021 showed that she had a bone edema on the lateral aspect of the tibial and tibial plateau, both in the T1 and T2 images. And then, so I repeated an MRI because she wasn't better. And these were done in August of 2022, and you don't see the changes that occurred from her original trauma. In fact, I went through this with the MSK radiologist, kind of tooth and comb, just to see if there were anything that we could see in the proximal tib-fib joint surrounding this. And he looked at it with me, and we could not see anything abnormal, no ligamentous tears or changes to the joint. So this is just sort of a lateral to medial a sagittal view, looking at that bone edema on the lateral aspect of the knee that you can see. You can see it extend down into the fibula here on this MRI from September of 21. And then on the images from August of 2022, there's really no changes in there. So I'm, at this point, I'm kind of stumped because she's really has no reason to complain. She still has this feeling of her knee giving way and instability, and has not gotten better. So I had her back in the office, and I said, well, let's do a ultrasound. And looking at ultrasound, let's see if we can see anything else. And originally my plan was to look at the literature and say, well, with the resolution of ultrasound, that being 3 to 4 times the spatial resolution of an MRI, can I hone in on the proximal tib-fib joint and look at the ligamentous structure and see if there's any subtle changes. And but that plan didn't go through, but we still did a complete evaluation, but we found something else that I'll show you. So, I mean, if you look at a normal knee diagnostic protocol, this is courtesy of the AIUM, who we've been certified through. We did the protocol according to them, looking at long and short axis views here. I mean, this will be in the slides, so I won't go through it all. But, some of the views I wasn't as concerned about. I thought, well, maybe she does have some pathology of the inferior aspect of the patellar tendon, but I really wanted to hone in on this lateral aspect of the knee to make sure we weren't missing anything, especially in the popliteus tendon, in the fibular collateral ligament, and especially the biceps femoris and or the distal IT band. So that was my reasoning to do this protocol, and then we added something to it. So I just included some of the images that we had from our complete evaluation, looking at the quadriceps tendon and long axis and short axis, the patellar tendon in a similar fashion, and then looking at the suprapatellar space, looking for any subtle, I mean, it's normal to have a little bit of fluid in here, but I'm looking for more effusion, synovitis, or other changes, which I did not see. We looked at the distal femoral cartilage, and I find it more helpful to look at this short axis image to get a sense of the femoral cartilage near the trochlea, and I didn't see anything there as well. We moved into the medial aspect of the knee, looking at long and short axis views, the MCL, the medial meniscus, and then the pes anserine tendon and bursa, both in long and short axis, again, because this patient did not have any medial symptoms. I wasn't, my radar wasn't up as much there, but I didn't see anything in there. And then we looked at the popliteus tendon. We tried to really hone in, and I know there are very good sonographers here. I try to get a long axis view of the popliteus tendon. I typically look at the popliteus tendon, especially in the post-arthroscopy patient who's having lateral knee pain, because I've found that it tends to impinge on sometimes the components, especially the polyethylene component of the total knee replacement. But I looked at that. I did not see anything in the popliteus tendon. And then really honing in on the biceps femoris tendon in the long axis, I did not see any pathology. It has a normal fibular pattern as it attached to the fibular head. And the fibular collateral ligament appeared normal as well. I didn't see any abnormalities in that. And then our left IT band, and I apologize, our long axis view of the IT band is not included here, but we followed that down to Gertie's tubercle. I thought, well, maybe she has pathology in that as well. And again, I didn't see anything. The normal architecture of the lateral meniscus with the transition of fibers from its circular to vertical are noted here, both in long and short axis. I can't see that in short axis, but I didn't see anything in that as well. And then some additional views that are part of the protocol, looking at the posterior aspect of the knee, looking to see if there's any abnormalities such as a Baker cyst. This would be, again, more posterior medial, not on our radar, but you never know. I mean, sometimes when the patient has an effusion and they have an irritated knee, you'll see an infilling of that semimembranosus gastrocnemius bursa. And so sometimes it's a clue that there's more going on in the knee, sort of the same way I look at the biceps tendon sheath in the shoulder for intra-articular pathology. And then the semimembranosus muscle and tendon. And again, I didn't see anything in that as well. And we even did additional views of the gastrocnemius muscle and tendon. So I was kind of at a loss. So sorry about that. We looked up how we could look at this with ultrasound. So when we had the patient come back following this negative MRI in August, we had her come back and said, what can we do to further this diagnosis? And so this article from Taiwan looked at dynamic evaluation of the proximal tib-fib joint. And the first three photos are from the study. The last one is ours, kind of showing you how we set our patient up. So basically, you measure the distance from Gertie's tubercle to the caput of the fibula, both in a neutral here, neutral position here, internal rotation here, and external rotation here. But where the most changes they saw in the article was this, which is forceful knee deflection. So basically in the study, they had the patient strapped to the chair. We went over to physical therapy and got a few nylon straps that wouldn't stretch. And the transducer is sort of sitting in this axial plane here. You can see me holding it there. But we had a hard time with this strap around her leg. We just had too much play anytime we put it on like a leg of a piece of furniture or something like that. So I ended up strapping it around my foot. And it also allowed me to sit in this position. You can see one of my assistants here, they're running the ultrasound machine, and I'm actually looking up at the screen. So it's a nice thing, I can line it up and do it there. So this is kind of the view, and the patient basically slides their foot backwards, like they're going to slide it under the chair here, and with as much force as they can, and hence the strap around their waist here. And just with dynamic diagnosis, if you start with physical examination, basically, I mean, all of us that have examined proximal tib-fib instability, you basically take the head of the fibula and move it in an AP translation to see if there's increased movement and compare it to the other side. Cadaver studies show there's normally a range of 1 to 3 millimeters under physiologic loading, and anything beyond 3 millimeters is considered abnormal. Well, in this study, if you look down below in one of the tables from the study, on the affected leg, starting with their standard neutral position, they were about equal on the affected and unaffected side. But with additional, this is the measurement with the force flexion. There was a subtle opening of approximately 3 to 4 millimeters or greater than 3 millimeters in this study done. And there was a slight opening with the unaffected leg as well. So, and this study, it's interesting because I'm like, how did you get 20 patients that have this condition? Because for those of us that have been in practice a while, I mean, I've seen, I still remember I've seen about 3-4 cases. And the first case was actually presented by one of the orthopedists in Minneapolis. We had these big sports medicine meetings in Minneapolis and get together, and one of the orthopedists presented it on a Friday morning grand rounds, and he showed the subtle popping of the proximal tib-fib joint on this patient that was walking. And I still remember the old Sony video. It was really crude, but all the orthopedists in the room were going, what do we do with this patient who now has this condition? But in this study, they found 20 patients in Taiwan that had this condition. And so they brought them in for this evaluation. This was the only study I found that showed any, or at least showed any merit for using ultrasound to look at the proximal tib-fib joint. But basically, they showed almost a 4 millimeter difference on the affected side, and then 1 millimeter on the unaffected side. It was 95% specific, but it was only 65% sensitive. So its sensitivity is not very good. So you're probably thinking, well, what did we find? Well, we found, so the left knee is the affected knee, so it's going to be over here. The right knee's over here. The fibula is here, so this is going to be lateral. Well, lateral is going to be towards the middle of the screen. This is Gertie's tubercle over here. We tried to pick a point that was equal on both. So when we did our neutral view, this is our neutral view right here. It was 2.77 centimeters. And then this one over here, sorry, my sidebar is in the way, is 2.54 centimeters. So it was open on that side. And so in this, down here was our flexion view. So if we look at our flexion view, it maybe slightly changed over here. It didn't change at all on this side. So I question whether we were doing it with enough force. We had the patient, whether the friction of her shoe on the ground may have affected it. We tried a couple of different measures, but with flexion, it stayed about the same. So it didn't change. And so that was our flexion view. So it kind of gave you the meat of the matter here. It's interesting because if we did internal rotation of the foot here, it stayed about the same, 2.77 centimeters. But with external rotation, it actually opened up a little bit at 2.84 centimeters. So basically, and I didn't include my complete report, but I would have reported on the individual views that we had for a complete report, but just to not make this slide too cumbersome, I left that out. But basically, at the end of the report, I said there was widening of the left proximal tibiofibular joint at rest and with active flexion, and said that this could be associated with left proximal tibiofibular instability. And although ours doesn't show what the study did, I thought there was enough widening there to make a statement about that. So basically, I wanted to present this to this group because after looking through the literature, I only found this one article, and this article was published in 2021, and it's a reference at the end here. But I wanted others in the group to see or discover, whether this is helpful for looking at the proximal tib-fib joint. So, and also during my research for this, and I didn't go through the MRI studies, it was beyond the scope of today's meeting, but the MRI studies, a lot of those do show with the initial trauma, the bone edema we saw in the first MRI. There's several case series that span 10 years that shows some ligamentous disruption, complete disruption, but I don't know, there's not a lot out there. And then the question is, does this ultrasound evaluation help clinically? The patient is symptomatic, her exam shows increased translation, she can reproduce movement of the proximal tib-fib joint. Does this give us more ammunition? Well, I can tell you in my world it doesn't, because the orthopedists that have seen her in consult since I've done this, she's had a number of diagnoses, including patellofemoral syndrome and CRPS, which doesn't fit the profile of this patient. So anyway, that's all I have for this morning. Hopefully I stayed within our time frame here.
Hey, Tony, I'm just going to ask a quick question before we discuss. What plane did you, on the ultrasound, did you measure the proximal tib fib joint, was it a straight coronal plane? Was it more of a posterior lateral probe orientation?
So it's gonna be more it's gonna be more in an axial plane. So I could go back to since we're off it, but I could go back to that. But basically, I'm in an axial plane. I basically have that planted on the caput of the fibular head, and then it's spanning over to Gertie's tubercle. So it's in axial. Does that make sense?
It would seem a little more like a coronal plane to me, even with the flex knee. But yeah, so you're just more on the lateral aspect, because like when I evaluate the tib fib joint, you know, I mean, there's definitely a width to it. You can evaluate probably 2/3 circumferentially, and I don't know if that would make a difference.
I mean, it's more. I guess it's more an axial oblique because the fibula sits somewhat inferior to Gertie's tubercle, so I've got it obliqued up to the prominence and the attachment of the IT band.
Yeah.
So
okay.
So it's probably somewhere in the middle, I guess, between that and coronal, but more axial than coronal.
That was Anthony, that was super interesting. You know, this is, I agree with you, and that this is certainly not a really common condition. I'd be curious to, you know, hear from others on the call who've maybe seen more than I have. I think I've seen about 3 or 4 patients, you know, that have been sent for evaluation of this particular problem. And I've always struggled to know, how do I objectively diagnose it? And I had not seen that paper that you showed us, and so that was, I'll have to take a look at that. But in the past, what I've done is I've had people you know, lying supine with their hips flexed maybe about 45 and knees flexed about 90, and I've kind of put it on that very similar kind of orientation as you had there, essentially showing that anterior tib fib joint. And then I've just manually kind of you know, tried to translate the fibular head anterior, and I've just tried to compare that to the other side. You know, some people, when you examine their knees, they have just incredible amounts of tib fib laxity on both sides, right? They're just like, like you can almost dislocate the entire thing, and that's normal for them. And so I've tried to use kind of a somewhat quantitative but hard to quantify side-to-side comparison for instability in these in the past. And it's definitely a challenging you know, thing to diagnose. The couple of patients that I've been convinced that this is the problem on are people who have, you know, gone from doctor to doctor to doctor to doctor, you know, complaining of lateral knee pain, and you know, have had 18 MRIs and things like that. And so it's definitely a challenging problem. I don't know, Doug or Ryan, have you guys seen this more than I have, and have any good tips on it as well?
Yeah, I haven't seen it any more than a couple cases, and I've struggled to come up with something standardized. So I haven't seen that article either, but it's very qualitative. And the problem is the treatment really is an arthrodesis. And so the case I can remember also had some irritation to the common fibular nerve. And that was actually more the presenting case. And I guess to sort of highlight your point, Brennan, you know, a lot of people have laxity there. And so that side-by-side comparison is important. But the question is that, quote, normal laxity, can that irritate the common fibular nerve just in and of itself, which I think it can.
Doug, you know, from a treatment standpoint, our surgeons here have a different technique. They do not do an arthrodesis for this. What they do is they strip a band of the posterior IT band with like a tendon stripper, and then they actually drill a tunnel through the fibular head, and they dock that IT band through that tunnel, and then they anchor it back into the tibia. So they essentially form a sling with kind of a band of the IT band. And so there is, some motion allowed still outside of an arthrodesis with those folks.
Interesting.
I don't know if that's
Yeah,
a technique. I don't know if they developed that or how they chose that route, but
yeah, and with this patient, I think that this patient would be referred to someone who would do that, because the community orthopedist, even the one at a local university, I don't really think he understands the scope of the problem. So this patient, at least when she saw me, did not have any fibrillar nerve symptoms, any paresthesias, even though you could see that happening with the pull of the biceps femoris on the head of the fibula, and how that would occur. So.
The only other point I would like to make is just going back to the protocol and again, sort of highlighting what Tony said, the importance. And so for me, the most common reason I'm doing a lateral knee exam is for the common fibular nerve. And so I do what we call a lateral knee protocol. So that includes some of the anterior joint images. And then I don't go to the medial, but I'll go to the lateral and sort of just to highlight, the importance that the proximal tib-fib joint should be part of your lateral knee protocol. I admit I don't do routinely do dynamic, because going back to my point, I'm not sure, what to do, because it's very qualitative. And most people just have problems with older people just have problems with the nerve. But yeah, so that's how I approach it, is that I just have for someone who comes with irritation or symptoms of the common fibular nerve, that's a lateral knee protocol for us. And the only difference between that and, let's say, someone we're trying to rule out lateral meniscal tear or lateral collateral ligament injury is that our images of the common fibular nerve are just in more detail.
Yeah, in retrospect, I should have done that on this protocol, but I did not. I think about it again more, like you said, Doug, in elderly patients, and I'm really looking for a cyst coming off of that proximal tib-fib joint and its effect on the recurrent articular branch coming off the fibular nerve as well. Martinoli, in his textbook, describes that.
Mm-hmm. Right.
all right. Well, unless anyone else has any comments they want to speak up about, I think that will end it for us here today. We will be back on January 13th, I believe, which is, maybe 4 Fridays from now. And we'll be starting with our fellow series of the AMSSM Sports Ultrasound Case Series, which will run from January through June. And so be on the lookout for emails. We will be switching the Zoom link starting in January as well. That will be not hosted through the University of Iowa anymore going forward. All right. Thanks, everyone.
Thank you.